coordinator, and Pamela Cornell, our nursing director for education. We welcome you to another Sovah Health CME program. Um, the program this evening is a 1.5 hour credit for Category 1 physicians AMA CME credit, and for 1.5 hours of Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern States CME Collaborative as an ACCME recognized physician CME accreditor. It's also accredited by the Virginia Nurses Association, an accredited approver with distinction by the American Nurses Credentialing Centers Commission on Accreditation. The program this evening is designed to promote several desirable physician or provider attributes, including our providing patient-centered care, always employing evidence-based medicine, and working in interdisciplinary teams. Um, the needs assessment this evening was based on the public health high prevalence of diabetes in our community and the medical literature review of the 2026 American Diabetes Association Medical Management of Diabetes. Excuse me just a second. Vinay, I think Dr. Santine is trying to call
I'm
us.
taking care of it. I'm
Okay,
taking
thank
care of
you.
it. Mhm.
Okay, thanks, everybody. This review, the 2026 ADA Medical Management of Diabetes, is published every year in the first supplement of Diabetes Care, an ADA journal. And everyone involved with diabetic care should each January review this publication for the basic evidence-based medicine consensus generated opinions about managing all forms of diabetes mellitus. Dr. O'Neill, Dr. Santine, myself, and members of the Sovah Health CME committee have nothing to disclose as far as commercial relationships. The program this evening is supported by an educational grant from the Ralph Landis Medical Education Fund. There is no commercial support for the program. This fund, which resides at the Danville Community College Educational Foundation, was established when Dr. Landis, the founder of the Southside Urology Clinic, also known as the Danville Urologic Clinic, when he retired, he provided a significant amount of money to establish an endowment for medical education for healthcare professionals in our community. Tonight, you have two ways to get the eval form at the end of the program. Vinay will put a QR code in the chat, and she'll also put a link you can click on or type into your browser to get to that form. We urge everyone to take a few minutes and complete the eval form when you finish the program. It contains some 7 questions, and we always remind everyone, please take time to respond to the question about how you plan to make a change in your daily practice based on what you learned this evening. And this is for everyone, not just the providers. When you submit your eval form, you will be asked to also re-enter your name. Please give us your full name because that's what will appear on your CME certificate. Please no nicknames or short names. If you have someone with you tonight sharing your logon, which we welcome, please let one of us in the CME office know about this so we can provide credit to that person for their participation in the program. We always remind our Sovah Health residents that they do not have to keep up with their CME certificates. Your coordinator will do that, and we will send that to them at the end of the program. For nurses and nurse practitioners on the call, in order for you to receive your CE credit, you must submit an evaluation form. And for everyone else, it's voluntary, but we really hope everyone will. These evaluation forms we take very seriously. They're reviewed, summarized, they're shared with the speakers and planners and help us provide better educational programs. Every time we do a program, I pause at this point and thank Vinay Mayo and Pam Cordell for their help in putting together this program and all the programs that we do. Without their help, we just could not do this, and I greatly appreciate all they do on every day. I've spoken with Dr. Santine and with Dr. O'Neill. They both really would like to have questions or comments they would like for you to engage them for the program this evening. And so if you have a question, you can type it in the chat. You can click on the raise your hand, or quite honestly, you can just speak up. Neither speaker has a problem with being politely interrupted, and they welcome comments. If you do a verbal question on live, we ask that once you've asked your question or made your comment, you mute your phone so we don't have feedback. Let me highlight to you the next upcoming program on June 11th. We will have the second in a series of quarterly programs that are designed for emergency or acute care situations. This time, we're delighted to have two of the emergency room physicians from the University of Virginia, Dr. Kearns and Dr. Byrne, and they will be talking about a series of issues that now are said to be somewhat controversial and that there's different opinions as these new evidence-based medicine treatments evolve. These are listed on the learning objectives as you can see on the slide, and we'll send all those details out to everyone in a program announcement. The other programs, I'll just give you a brief highlight, is in July, we will be doing two GI programs, one on colon cancer screening with Dr. DeWiz, gastroenterology, and then 2 weeks later, a review or update on the management of inflammatory bowel disease. There's lots of relatively new drugs making this a very effective treatment, and Dr. Natalie Wong from Duke GI will be doing that program. So this evening, I'm delighted to introduce two speakers, both of whom we are just so pleased and fortunate we can have them participate. And I think the way I'll do this, I'll tell you about Dr. O'Neill, and then when he finishes, I'll come back on and introduce Dr. Santine to you. Dr. Eric O'Neill is one of our senior residents. He's a third year. He originated his life in Portsmouth, Virginia, and began his educational journey at VCU, or the Virginia Commonwealth University, where he received his honors and Bachelor of Science degree in chemistry. While there, he was recognized by VCU as the student of the year, first year student of the year in their acceleration academic program. He then completed his MD degree at St. George's University School of Medicine in Granada and has been with us at Sovah Health for his 3 years of internal medicine training, which will soon be completed. While here, he has been recognized for his leadership and academic excellence, having been chosen as the chief resident for the internal medicine residency. In addition, he's been recognized for his compassion, patient care, and involvement in improving patient outcomes by being chosen as the January 2025 to January 2026 resident physician care champion. We're delighted to have him talk with you first about the management of type 2 diabetes. Those speakers will be echoing what the new guidelines are actually utilized. So as opposed to having a menu type lecture on going through the guidelines, Dr. O'Neill will do it with a case-based approach, and then Dr. Santine will be doing it from the perspective of interpreting that for outpatient care. So Dr. O'Neill, if you want to bring up your slides, you should knock mine off, and we're delighted to let you begin. Thank you.
Perfect. Can y'all hear me?
Yes, sir.
Okay, perfect. Thank you, Dr. Moore. I really appreciate the introduction, and thank you for allowing me and Dr. Santine to talk with you guys for the CME tonight. So I will go up on the slides and we'll get started. Are you able to see this? Are you able to see the slides okay?
I see them. Is everyone else seeing them?
Yes.
Great. You're good. Good to go. Showtime.
All right. Thank you so much, Dr. Moore. So as Dr. Moore mentioned, so Dr. Santine and I will be going through kind of a little more of the updated guidelines from the American Diabetic Association, and I will be focusing more on the case study for covering a patient that I took care of while at the Restley Clinic, and then diving into like a general overview of the guidelines. So for today's agenda, so as I mentioned, we'll do a general overview for diabetes. We'll dive into the case presentation. We'll dive into the updated guidelines and then do a general overview regarding for anti-diabetic medications and additional therapy. So what I wanted to do is to give us a nice little overview of what no of where diabetes mellitus. It's more than just elevated glucose in the body. It's a multifactorial disease that can affect multiple areas of your body. Your pancreas, your heart, your eyes, kidneys, things of that nature, including peripheral neuropathy. How it can be tested for is through multiple means. Attaining a hemoglobin A1C, which is a average measure of the glucose every 3 to 4 months of 6.5. Do a fasting plasma glucose of 126 at least twice, and or do a random non-fasting glucose of over 200. Overview for type 1 and type 2 diabetes. For type 1, that's primarily for destruction of beta cells of the pancreas, leading to overall absolute insulin deficiency. And there is a huge global prevalence and incidence, about 15 to over 100,000 people. And for type 2 diabetes, you have the corporation of insulin resistance. And it's more common, as you see with patients more with obesity and also physical inactivity. So this slide here is kind of doing an overview of type 1 diabetes and seeing the overall progression as it gets worse. You see the different stages going from stage 1 to stage 3, the incorporation of the autoimmune process, and then the overall loss of the beta cell mass. And you're seeing overall leading from normal glycemia to dysglycemia to hyperglycemia as time goes along. And with this picture, that's just kind of showing the overall mechanism regarding for type 2 diabetes or insulin resistance. As you see here on this visual, we see a defect in the GLUT4 transporter, which then ultimately leads to decrease in glucose uptake, making it a little more difficult for glucose to be processed effectively as it goes from normal uptake, like in places such as your skeletal muscle. Other key types, because there's more than one type of diabetes. An example would be latent autoimmune diabetes of adults, where you can have a late onset of type 1 diabetes in the 30s. You can also have a maturity onset of diabetes of the young. In addition, you can have gestational diabetes for those who know during pregnancy, and also an overarching view of secondary diabetes or diabetes type 1-5 as an example. So I will now dive into our case. So I have a 46-year-old female who initially came in to the Red State Clinic as a new patient to establish care with a severe custom medical history of type 2 diabetes. She formerly worked as a caterer and lost her insurance due to losing her job. And when I saw her on arrival, her sugar was almost 600, and she had unintentional weight loss, headache, and blurry vision. Um, and and she had a strong significant family history of diabetes with her paternal grandmother, and lives at home with the three children, husband, having primarily a sedentary lifestyle. So Viola's on arrival. She was hypertensive, met with class 2 obesity, and her only pertinent physical exam on arrival that she's obese, but no issues with lung sounds, heart sounds, or anything of that nature. When we did the actual lab work, her A1C was 17.8%, which is close to like an average of about 400 to 450. She had a lipid panel with elevated cholesterol and triglycerides, along with her LDL, and then breaking down her CMP, her repeat glucose noted to be 535, and then she had some microalbuminemia with about ibuprofen ratio of 57.6. So overall, these were her diagnoses, as kind of mentioned, kind of pre-medicated, as suggested from her previous slide. So what I want us to kind of think about is, how would you all would manage this patient in regards for the guidelines? What would it be the next step? How to manage her diabetes when she has a lack of insurance, it can't afford to be seen, and how could the situation be handled differently with the new updated guidelines? So as far as for my management for this patient, I encouraged her to go to the emergency department to receive insulin therapy to get her sugars under control. And one barrier that we dealt with is that she could not afford to come to the rest of the clinic for consistent visits due to the loss of insurance. I've called many programs to see if they could help her with no medication costs and things of that nature, and I would call her every 1 to 2 weeks to make sure that I was able to stay on top of her for to make sure that she not get hospitalized for DK or any diabetic complications, but also to make sure that she incorporated lifestyle changes, changing her blood pressure medications, addressing any sort of symptoms or concerns. And eventually, over the course of 6 months, I was able to cut down her A1C from 17.8% to 8.8%. So now, or we're getting to the primary reason for the CME is going through the guidelines. So going through the guidelines, no detail by detail, there are a lot of little nuances and intricacies that I may not necessarily cover, but if you have questions, I'm more than happy to answer them. But I want to give two overarching themes to approach for the new guidelines according to the American Diabetic Association. One is the improving outcomes in general populations, and the second one is use of diabetic technology. So the first diving into the improving outcomes populations, there were different themes that kind of center around this concept. The first one would be lifestyle changes. The first one they're recommending having weight loss by about 5 to 7% in order to optimize glucose control. In addition to optimizing kidney function and with blood pressure, with standard antihypertensives, um, and then things of that nature. Next thing would be the use of glucagon kits. So there's not much, at least in the diabetic updates, as far as for statistics, but there was I guess, a theme accorded of incorporating for more of an advocacy to have the diabetes awareness more prevalent in public locations. Examples for schools, including to have glucagon kits, diabetic kits, things for hypoglycemic protocol, etc. The biggest one that I did want to talk about was monitoring for MASH or MAFLD. When I did my gastroenterology rotation a few months ago, I was talking with one of the gastroenterologists, and one thing to incorporate, not just for endocrinology, but for primary care, is to incorporate what is called the FIB-4 score, as you see on your screen. The incorporation of this score is to screen for people who may need what's called a fibro scan to essentially screen for those who may need further evaluation, example like for fatty liver disease and things of that nature. So how you would calculate that is you use your age and your AST level, multiply those together, divide by the platelet count, and then you multiply that by the square root of the ALT. And if memory serves correctly, if it's above at least 2.67 or higher, then patients would then qualify to have a fibro scan and for further workup. Other examples to include, for older adults, for those who are diabetic, to have earlier screens for osteoporosis. So that would include for DEXA scans, things of that nature. So for those who are involved in primary care, that'd be something to consider for your older diabetic patients. And this slide kind of gives like an overall general algorithm when it comes to managing diabetic patients. So the overall theme, at least from the update, is that every patient is different. And the overall goal is to individualize glycemic targets. So what you want to do is make sure that you have, a good history for your patients, including for diabetes, and then you want to assess for any sort of comorbidities and/or complications such as heart failure and also chronic kidney disease. And this slide also breaks down the kind of need for what kind of regimen you can use for your patient. So, for example, if you have a patient who is overweight, the preferred thing would do is incorporate like a GLP-1 agonist or follow with like an SGLT2 or metformin. And based off where the A1C is, there's a hierarchy for what medications to use. So now diving to the second part is the use of diabetic technology. So examples would be using glucometers and continuous glucose monitors. So with the updated guidelines, it dives in kind of dives into that for patients who are being diagnosed with type 2 diabetes or also type 1 diabetics, it's important to incorporate continuous glucose monitoring at a time of diagnosis. And why is that? It's to increase compliance with medication and therapy, and also to optimize glucose control. And also the importance of these monitors is to also help associate with trends, and that way you can see over time whether glucose levels are elevated or drop low in order to optimize the glucose control. And in previous years, you may have required like C-peptide levels or sort of insulin antibody levels if you were type 1 diabetic. But as of now, they're no longer required to make these monitors a little bit more available to the public. The additional examples can include insulin pumps, could be tubeless, so that patient could have a better quality of life, and also to make things easier for these patients to check their sugars, and also insulin patches. So a few years ago, the article came out for the extent of insulin patches for patients who are scared of needles, that insulin patches can also be used to bypass patients' fear of needles. And as of right now, at least from the current studies that I've seen, these patches could hold up to about 200 units of insulin per patch on average, but the cost was another story, probably about like range from $4,000 to $6,000. So may not be the most may not be like the first line of choice, but it's something to consider for those who are really really scared of needles, and also to help increase compliance and optimize glucose control for these patients. This slide is basically kind of summarizing what I talked about, using automated insulin delivery as a way to as a preferred method for those with type 1 diabetes, and also those with type 2 diabetes for the injections, including for children as well. And then the use of continuous glucose monitoring for those on insulin, and also those not necessarily because of cause hypoglycemia, no need for C-peptide levels or presence of insulin antibodies, and those who are not meeting their glycemic goals, or only for those who are on basically insulin as well. So now I'm just going to give a generalized overview of the antidiabetic medications. So you have, your oral agents, include your biguanides, sulfonylureas, guanides, glutazones, DPP4s, your SGLT2 inhibitors, and I'll talk about the GLP-1s, and then of course insulin in general. So just for the oral agents, again, this is kind of like a nice little slide that I saw to kind of give like a generalized overview of kind of how these things kind of work in terms of their mechanism of action, which I'll dive kind of summarize as we go along through it for this presentation. So for the oral agents, that will include like such as metformin to inhibit hepatic gluconeogenesis. You have your sulfonylureas, which include your glipizides, which focus on enhancing insulin secretion through depolarization to the potassium channels to allow for calcium influx. And you have your glinides, which are some of the sulfonylureas, but they act on different sites with a faster onset and a shorter duration of action. Then you have your glutazones, which activate your PPAR gamma receptors, but just note to be careful with patients who have heart failure, as there's like probably like a 8% chance for those have an adverse effect with heart failure. And you have your DPP4 inhibitors, which can increase your overall levels of GLP-1 and GIP, which help increase insulin secretions and decrease glucagon secretion overall, to kind of give that counter-regulatory hormone balance in favor of insulin. And also, I just want to take a minute to kind of talk about incretins, and I want to thank Dr. Santon for allowing me to use this slide. So there was a study back in 1964, where oral glucose versus IV glucose was studied to see where there was an overall difference in terms of insulin response over the course of the 60 constant infusion of glucose. And it was shown that the oral glucose showed a more increased response versus IV glucose, which I thought that it was pretty interesting. And dive into the GLP-1s. You have your dulaglutide, and all those listed there. But the essentially what they do is insulin release after glucose consumption. It can also overall help with weight loss and things of that nature. Um, this slide here is just kind of showing the overall all the benefits and side effects. So keep in mind, for those who are on like for glipizide or sulfonylureas, be aware of hypoglycemia, which can cause the overall worse effects, especially for older patients. So just something to consider. For metformin, it's kind of one of your first line to help for control for diabetes. DP4 inhibitors, note for the potential increase of heart failure. SGLT2 inhibitors, no for UTI. Also for SGLT2 inhibitors is also can increase for for polycythemia, and also for euglycemic DKA. So something to consider. And then for GLP-1 agonists, just to keep in mind for overall side effects, like for nausea, vomiting, diarrhea, and things of that nature. So this slide here is just kind of going overall the general theme of insulin. You have your rapid acting, your short acting, intermediate, and long acting. So as far as for like the overall set goal for your patients, if they're going to be started on insulin, ideally would be to have a long acting insulin, and then follow it up with short acting insulin to kind of mimic insulin release, as people eat their meals throughout the day. So so my takeaway points here is there are a good amount of guideline changes, but the biggest thing to note was the um, lifestyle changes, and make sure that you advocate for your patients. Continue to incorporate preventive measures, and incorporating technology as soon as patients are diagnosed with diabetes. And also too is also important, to make sure that we have less barriers, to make sure that patients get treated appropriately to optimize glucose control, increase quality of life, and to also encourage the patients to make sure that we're advocating just for them, but to make sure they have better quality of life. And these are my references, and I appreciate you all listening, and we'll make sure that there are, make sure that anyone has time for questions before we transition.
Thanks, Dr. O'Neill. Anyone have questions for Dr. O'Neill before we move on to Dr. Santin's presentation? Anything in the chat, Vinay?
No comments in the chat.
Okay, well, thank you so much. And I have to point out, Dr. O'Neill ended his talk with the University of Buffalo picture here, which we're delighted he's going to be beginning an endocrinology fellowship there in not so long a time. He's only got about I don't know, 6 to 8 more weeks with us here, and we'll let him, if they say, shuffle along to Buffalo. And We're so proud of him. We really are. Thank you so much. Dr. Santain, let me introduce you briefly. While if you want to go ahead and bring up your slides, and I'll share with them your remarkable story. Dr. Richard Santain is a member of the Faculty Endocrinology Division at the University of Virginia. He started his educational journey at Holy Cross College, and then he received his MD degree at the University of Michigan in Ann Arbor. His internship and residencies, his JR year were at Cornell, and that was followed by a senior residency, again, back in Ann Arbor at the University of Michigan. His endocrinology fellowships were done at the University of Washington in Seattle. He has subsequently had major attending faculty roles at the University of Pennsylvania, other hospitals, and for the past number of years at the University of Virginia. Dr. Santain is a world-class investigator. He contributed mightily to the concept of, if you will, endocrinology within the specialty of oncology. He made major contributions to understand the effect of estrogens on the development of breast cancer and modulating breast cancer growth, and was instrumental in the development and bringing to market and the effectiveness demonstrated of tamoxifen. Over the years, he has been the author, editor of over 100 books. His CV includes over 400 peer-reviewed, high-impact journal articles. Finally, he's more recently significantly contributed to the application of telemedicine to rural areas in Virginia, particularly southwestern Virginia, and has made major impact on improving diabetic patients' care. It is a true privilege and honor to have him be with us this evening. And so, Dr. Santain, as I always say, thank you so much, and it's all yours. Thank you. Your slides look great. You may be muted. I don't know. I think you are muted. You were good before. You just need to go to screen show, I think. Slideshow from the beginning.
Okay, now you can hear me?
Yes, sir. We've
Perfect.
launched your slides. We're seeing your, you just need to share the slides and bring those back up.
Okay. So it says share.
You were shared before.
Yeah. There we go. Okay.
Yeah. And then just, yeah, screen show, slideshow from the beginning, your showtime. Thanks. You're good. There you
Okay.
go.
So Mike, I wish my wife was here to hear that introduction, but thank you very much. So I'm going to talk about guidelines for type 2 diabetes. Type 1, we're not going to talk about. Now, I have to own up to everybody that I don't actually like guidelines. And the reason is that guidelines tell you what to do, but really, when you take care of patients with diabetes, you have to figure out why you're going to do it. So I'm going to focus really, we'll follow the guidelines, but I'm mostly going to tell you why we do things that we do. So the current ACE, American Association of Clinical Endocrinology, and the ADA guidelines, I think, are too complicated. 100 pages, you can't memorize everything. So I'm going to try to simplify this. And the concepts about priorities for treatment of diabetes, they've recently been updated. So what's new? Well, there's a major emphasis now on obesity and comorbidities. There actually was a debate at the Endocrine Society 3 years ago. What's most important with type 2 diabetes? Treating the diabetes or treating the glucose? And basically the answer to that was you treat both. The other thing is that every patient is different. So we're talking about personalized medicine. And we need to set individual goals for hemoglobin A1C and also for the continuous glucose monitoring parameters. So I'm going to start with what do you do when you first see a patient with type 2 diabetes? And this is usually a patient in clinic. So you really want to think not just about their diabetes, but you want to think about the comorbidities. So do they have atherosclerotic cardiovascular disease? Do they have hypertension? Are they obese? Do they have chronic kidney disease or liver disease? Do they have hyperlipidemia? And are they smokers? And the reason we focus on these is that the therapy of these patients is really directed primarily toward these particular comorbidities. You want to try to reduce them, prolong the patient's life, and increase the patient's quality of life as well. By the way, I forgot to mention that I thought Eric did a wonderful job, and I just wanted to congratulate him. I neglected to say that. So how do you know about cardiovascular risk? Well, there are major risk factors, which you all know: age greater than 40, males greater than females until the age of 60, when it's more common in women, hypertension, chronic kidney disease, equal or greater than 3B, a family history of premature atherosclerotic cardiovascular disease, low HDL cholesterol, high non-HDL cholesterol, metabolic syndrome, and MASLD and MASH, which Eric talked about. So I like the risk calculator, and this is the American Heart Association, American College of Cardiology calculator. It takes time to do this, which is the problem. But the advantage of this is it integrates these risk factors to predict the percent of events at 10 years. And those risk categories then are used to recommend the use of standard or high-dose statins. Takes time, but in my opinion is quite useful. And I'm hoping that in time, Epic will do this for you. If you don't do the calculations, it's pretty reasonable to know who's at very high risk for atherosclerotic heart disease, hypertension, hyperlipidemia, and so on. So I always emphasize this: is the standard history and physical exam useful in determining the presence of atherosclerotic cardiovascular disease? Now, you're going to laugh at this, but my experience goes back to when I was a resident. And I did a study trying to figure out who had atherosclerosis in patients with diabetes. It's published in the Archives of Internal Medicine if you want to see that. And so I studied about 200 patients, and if they had a history of intermittent claudication, cerebral vascular disease, or coronary artery disease, I was worried about atherosclerotic cardiovascular disease. But the physical exam was pretty important too. So if you listen to the carotids, found bruits, abdominal bruits, absent dorsalis pedis or posterior tibial pulses, and so on, that is a tip-off really that they had atherosclerotic cardiovascular disease. Well, how good was this assessment? Well, in the patients, the 100 controls, let's see if this is going to work. Yeah. So in the 100 controls and patients with diabetes without atherosclerosis, the triglyceride levels here, this is one lipid that you have, are very much more normal than the patients that had atherosclerotic cardiovascular disease. And I just say this to emphasize that the history and physical exam, really important, and it does help you. And you can see in this population of patients, 50% of the patients with diabetes had triglyceride levels elevated if they had atherosclerosis. The controls and the patients without atherosclerosis didn't. Well, it's interesting just thinking about this because triglycerides in those days, that was back in the last century, by the way, were not really thought to have anything to do with cardiovascular disease. But it turns out now with studies looking very carefully, triglyceride reduction in myocardial infarction shows that you can reduce the risk by lowering triglycerides. There's another study here by Marston that came out in 2019. So this topic is still controversial, but triglycerides are important and probably do contribute to cardiovascular disease. So as of yet, there are no recommendations regarding treatment of mild elevations of triglyceride, but you do need to treat triglyceride if the levels are over 500 because patients can get pancreatitis, and you don't want that to happen. So the next thing that you do, you're going to evaluate for cardiovascular disease. You need to evaluate for hypertension. So the recent criteria are really much more stringent than they used to be. You're hypertensive if you have a systolic over 120, a diastolic over 70. I don't like to measure blood pressures in the patients in the clinic because patients are stressed and what have you. So I really recommend home blood pressure measurements. Have them do several of them so that you know that they really average in this level that would enable you to make a diagnosis of hypertension. Now, the problem is that in older patients, you try to get the blood pressures down below 120 and 170, they might faint, they get dizzy, they're going to fall. And so you really have to be looking at the patient and to make sure that if you get the blood pressure down far enough, you're not causing more problems than not. And then, of course, you're going to initiate therapy. So what about the initial evaluation when you see patients? Well, you want to see if they have chronic kidney disease. Again, that will affect what treatment you use. Have they had a cerebrovascular accident? Do they have obesity, hyperlipidemia, or smoking? Now, one of the questions that comes up is what laboratory data should you do? Well, routinely CBC, comprehensive metabolic panel, lipid profile, hemoglobin A1C, urine albumin creatinine ratio, because this predicts the risk of kidney disease later on. I haven't found the C-peptide helpful in patients with type 2 diabetes. We did a large study of 200 patients years ago, and it didn't help at all to know whether they should be on insulin or not. But if you do order a C-peptide, measure it random fasting and do the C-peptide with a concomitant serum glucose. And I usually measure TSH routinely in patients with diabetes over age 60, particularly the women, because hypothyroidism is relatively common in that situation. So what about these ancillary risk markers? Well, we can do an awful lot of things to get a better assessment of the risk of cardiovascular disease, but none of these are routinely recommended by guidelines. So apolipoprotein B, lipoprotein little a, non-HDL cholesterol, large HDL particles, small LDL particles, LDL, VLDL, very low density lipoprotein, high sensitivity C-reactive protein, and coronary artery calcium score. Did somebody have a question? No. Okay. You can do these, but when you have patients with type 2 diabetes, they're going to be on multiple medicines, and it's quite complicated. And one wants to take as simple an approach as one really can with these patients. So the guidelines don't recommend these guidelines, including calcium score on CT. So you've seen the patient, and we get 40 minutes to see a new patient, and it really will take all of that time to take a careful history, to do a careful physical exam, order all the laboratory data. So I usually wait until the second visit to go over various things. And there's quite an emphasis now on recommending lifestyle modification. So what does that mean? Well, it means increased physical activity. The patients that I see, walking seems to be probably the best way. Some of them have a personal trainer, but that costs money. And some of them can work out at home, but some type of increased physical activity. Healthy dietary changes, and a nutritionist helps me with this. Smoking and other tobacco use cessation. Some of my patients do chew tobacco, smoke cigars. And so you really want to ask about all aspects of tobacco use. want to reduce alcohol intake or have them stop alcohol. Everybody that I see in with type 2 diabetes, I have to say, has obesity. But that just says that weight reduction is really critical, and we'll talk about that. You want to assess sleep hygiene and manage those disorders, and it's really sleep apnea, and they have that if they're overweight. And it turns out that the GLP-1 agonists help sleep apnea. So it's important to know that. And I always tell patients that I see initially, if they're motivated, I can help them get their diabetes under control. If they're not motivated, I'm not going to be able to do anything. So you really want to assess for mood disorders and particularly the distress from the diabetes diagnosis, because they're initially diagnosed, they get really upset about that, and it takes a good bit of time to get to know the patients and tell them that over time we can manage this disease. And I mostly tell them they're going to feel better if we get their blood sugars down. And that's a good motivation tool. So then we want to treat the comorbidities. Well, you all know how to treat hypertension. And again, over 120, over 70, if you can get there. Hyperlipidemia. And again, one needs to know about the high intensity statins versus a standard statin. Treat with another medication if the triglyceride remains over 500. For me, that's a fibrate. And then use a comprehensive approach for weight loss to achieve the clinical goals. Now, I'll tell you later that I've not been very successful in getting patients' weights down, but I think that's changing now with the getting up to the maximum doses of the GLP-1 agonists or the dual GLP-1 GIP agonists like terpesitide. Where I work, we do have a nutritionist that helps, and that's something that we take a history to start with, but is quite useful. And I think all of us now have thought very early on about the use of a GLP-1 agonist or a dual agonist. And there's a lot of new information now about new drugs that are coming along and better ways basically use these agents. So what about glucose monitoring? Well, it's really helpful to use CGM and online computer access. I can't put it on the slide, but there's Dexcom and there's Libre 3. They're very helpful. And it not only gives you a rapid assessment of their glucose control, and I'll talk about the GMI in a minute, but not everybody can afford this, or older patients have a little trouble using it and so on. So it's acceptable to use finger sticks. And I usually start off 4 times a day before breakfast, lunch, dinner, and bedtime so that I can really see what the patterns are. And then depending on the situation, if they're not on insulin, we don't have rapid acting insulin on board, I'll often cut back to 1 or 2 times a day measurements. One thing to think about is if a patient measures their blood sugar every morning, and then you can rotate, take it at lunch the next day, dinner the next day, bedtime the next day. And after a period of time with only twice a day measuring blood sugar, you can get a pretty good idea of what their daily patterns are. So this is what I use in the patients that I see if they're on a glucose meter, and either they fill this out or I do, but you can see that we often will do before breakfast. Later on, we'll do a postprandial, so 2 hours after the meal, and then noon and postprandial, dinner and postprandial, bedtime, and so on. Occasional patients, I'll do 3 a.m. blood sugars, because when they're on insulin, they can get hypoglycemic in the middle of the night. And it's really hard to pick that up by history unless you measure this. So I do this rather intensively. The patients call me once a week and I fill this out. We do that so that we can get them under control quite quickly. If you make a change in their medication every week and their blood sugar comes down quickly, they really know that things are working, and it really helps a lot with their motivation. But I realize this is difficult on a practical basis in clinic, but it is doable, and in some patients it's helpful. So control of glucose levels. So as we talked about before, the choice of therapy is really guided by the glycemic targets and the comorbidities. So if the patient is overweight or has obese, I think first of all of a GLP-1 agonist or dual agonist. If they have atherosclerotic cardiovascular disease, I'm very concerned that they don't get hypoglycemia because they can get arrhythmias and so on. If they have congestive heart failure, we can use drugs that are beneficial for congestive heart failure. And these are the SGLT2 inhibitors, which cause the body to excrete glucose. And glucose is a pretty good diuretic. So on those agents, you can reduce plasma volume and help with congestive heart failure. If they have chronic kidney disease, you can still use metformin, but you have to be careful because it does accumulate. And if their eGFR is under 60, you have to lower the dose. If the eGFR is lower than 30, you can't use metformin. And then MASH and MASLD, one thinks now about two things. One is the GLP-1 or dual, or a thiazidone. I'm sorry, I always had trouble pronouncing that. If they have obstructive sleep apnea, again, the GLP-1 agents actually help with that and can reduce it by 50%. So these drugs, really, you need to think about what their actions are and then target the agent to the patient. So the choice of therapy also considers ease of use, access, insurance, and financial considerations. Eric talked about patients who don't like needles, and the Omnipod, it does actually have a needle, but it sticks there for 4 days. It's quite helpful because they don't have to inject themselves. Access is really quite important. And I found that telemedicine is helpful for patients that after they've had their initial history and physical exam, I can talk to them on the phone and save them the time to come into clinic. We can now charge for that visit, and it's helpful for the physician or the nurse practitioner, and it's also helpful for the patient. And then insurance and financial considerations. If there are any individuals who are Catholics in the audience and know about purgatory, this is really difficult. So you spend a lot of time with insurance and financial considerations. And I just tell the doctors, you'll save some days in purgatory and go to heaven very quickly if you've had to deal with these insurance and financial considerations. People in my office, the nurse practitioners and the pharmacist, help with this, but it's generally a nightmare. And then finally, you want to individualize glycemic targets. So the targets that we talk about, and I'll spend a little more time on this, are hemoglobin A1C. Now, it takes 3 months for the hemoglobin A1C to stabilize. So you can't use that on a very rapid basis. But if a patient is on a continuous glucose monitor, there's something called GMI, or glucose management indicator. And all this does, it averages all the blood sugars over the time that CGM is going. And from that, it calculates a GMI, which is a poor man's hemoglobin A1C. So I really like this because after a week or two, I can really see what the patient is doing because the GMI is down. The new target is time in range. And what this is a blood sugar between 70 and 180. And the target is over 75%. Some guidelines say over 70%. And then fasting blood glucose. And so you really need to think about the clinical factors. So if you have an 80-year-old patient who's got atherosclerotic cardiovascular disease, there's no way you want to get them down to 6.5 or 7, because if you do that, they're very likely to have hypoglycemia. So I usually set a target of 7.5% to 8.5% in patients that are over 60 or 70 that have atherosclerotic cardiovascular disease, have kidney disease, and other comorbidities. But if a patient's younger and they're a good patient and they follow up carefully, then you're going to set a target much lower. ACE says less than 6.5%. That's what the ADA says. The Endocrine Society is a little bit more generous and says you want to get them under 7%. So we talked about this before. So the selective therapies are based on comorbidities. So we know that the SGLT2 inhibitors are now known to reduce the risk of heart failure. So one would want to choose that. And also the GLP-1 or the dual. So the GLP-1 is Trulicity or Ozempic, semaglutide, or dual. And the dual has a GLP-1 and a GIP, and that's terpesitide or Mounjaro. Mike, I'm sorry, I had to mention the trades names because sometimes it's important. Wasn't supposed to do that. So if a patient has atherosclerotic cardiovascular disease or a high risk for that, the GLP-1 or the dual is quite helpful, and the SGTL2 is also will reduce the risk of that long term. Stroke and TIA, the recommendation is pioglitazone. Quite honestly, I'm not quite sure why that is true, but that's what the guidelines suggest. And what pioglitazone does primarily is it increases insulin sensitivity, knowing that insulin resistance is the major problem in patients with type 2 diabetes. So pioglitazone is helpful. Have to be careful with pioglitazone because it causes edema and it can cause heart failure to be worse. So it's a drug you have to be very careful with. And then MASH or MASLD, nowadays the GLP-1 agonist is shown to be helpful, and pioglitazone as well. And the guidelines now say that this should be considered as first-line therapy. But there's a drug out now for this. I haven't used it. It's just been recently approved, and it's not in the guidelines yet, but one can think about that. But for me, weight reduction and GLP-1, I really rely on this. So if there are none of these, so the patient doesn't have any of these comorbidities, they suggest that they go to what's called a glucocentric glycemic control algorithm. This is one of the things I hate because an algorithm doesn't tell you why you're doing or what you're doing. It tells you what to do. It doesn't tell you why you're going to do it. So if you have a patient who doesn't have a lot of comorbidities, the optimum A1C or GMI is equal to or less than 6.5%, or as close to this as is safe, achievable, and without undue hypoglycemia. Now, I have to own up to the fact that it's awfully difficult in patients with type 2 diabetes, in the patients that I see at least, to get them down to 6.5%. And I'll give you some data later, what I have been able to achieve. And then 7 to 8% if adverse consequences of hypoglycemia, or limited life expectancy, major comorbidities, or age greater than 75. And this is really personalized medicine. So you really have to sit down with the patient and think about what's going on and tailor the therapy to that individual patient. Now, the guidelines say something that I really believe, but is very hard practically to do. And that is to avoid therapeutic inertia and get to goal as soon as possible. And the target is less than 3 months. I like this because I'm partially retired and patients call me, and they call me once a week, and I can make a change every week. But if you can change the therapy as rapidly as is practical, this is a good way to gain the patient's confidence and to improve their motivation. And once patients feel better, they really know that you're doing something for them. They're not as concerned about living 5 extra years, but they really like to feel better. And so this changing therapies quickly is helpful, and particularly, as I say, to gain the patient's confidence. So, what are the additional parameters to monitor? Well, continuous glucose monitoring is really it's so much of an improvement over the finger stick. It's an improvement because the patients like it. That they know exactly what's going on, and with that, there are a number of parameters that we look at. So we have average glucose level, we have standard deviation, we have the glucose monitoring index, the time in range, and we have the percent low and the percent very low, and the percent high and very high. Just as a little bit of a sidelight here, I put the continuous glucose monitor on myself, and I had a huge dinner. And just to see that your blood sugar is going up from 80 to 280 all of a sudden, 20 minutes or 30 minutes after you eat, it's quite an educational tool because the patients have it on their smartphone and they can see exactly what's happening to their blood sugar. So this is, again, another good motivating factor. So what do you get with both of the two brand names of continuous glucose monitors? This is what you get. And the group at the Mayo Clinic several years ago standardized this so that all of the continuous glucose monitors show you the same thing. So you have an average blood glucose, and this can be for 2 days, 7 days, 14 days, 30 days, or 90 days. I usually look at every 7 days because they call me every week, but you can do it here. This average blood sugar at 132 is translated into a GMI, a glucose monitoring index of 7.9. This correlates quite well with the hemoglobin A1C. And then you can see how much the blood sugar fluctuates from being very high to being very low, but still with this average, and that's the standard deviation. So it gives you an idea of how high it goes and how low it goes. And then they show you a little something here. So this particular patient had 40% of their blood sugars in range. Now, we want to get them up to 70 or 75% in range, and we want to get the hemoglobin A1C down. So this is a helpful parameter. 53% high, 1% very high, 4% low, and 2% very low. So what I find is that during the daytime, patients can pretty much tell you when they're low or very low, but you can see this on the continuous glucose monitor printout. But where it's most helpful is at 2, 3, 4, or 5 o'clock when the patients are asleep. You can see that they go down at that point. And if you're doing finger sticks, it's very hard to get them to do enough nighttime blood sugars to really know that that's going on. So I really like the continuous glucose monitor for that reason, plus others. And then now we can see that there's a little bit of variation day to day. So you have this information. Patient rests on Sunday and maybe feels a little bit more motivated on Monday. Blood sugars are better. Sunday, maybe not so good. Went out Saturday night and so on. But you can get an idea of this. And as the week goes on, and Thursday, not quite so good. So you get a lot of information with the continuous glucose monitor. So what is this concept of glucose-centric glycemic control? So the first thing is that if a patient has a hemoglobin A1C over 10, it's very unlikely that you're going to be able to get their hemoglobin A1C and their diabetes under control without using insulin. There's some exceptions to that. You know, I've had a few patients that have just stopped all their medicines for several weeks and come in with a hemoglobin A1C of greater than 10%. Eric's patient had a hemoglobin A1C of 17.9. Absolutely, he needed insulin. And so what I usually do and what the guidelines suggest is that you use basal insulin, and that's preferably a longer acting one, plus prandial insulin. And if the patient's obese, it's a good idea to start the GLP-1 agonist or the dual agonist at the same time, particularly if they have marked obesity. Now, the other thing is that if the hemoglobin A1C is under 10%, and they have increased hypoglycemic risk, and this would be an elderly patient, it would be somebody that maybe would skip meals, then what you want to think about is metformin. Now, it's interesting when you talk to patients, they don't understand why, if their blood sugar is 120 when they go to bed, why is their blood sugar 280 when they get up the next morning? Most people don't realize why that is. Well, it's because the liver makes glucose if there's not enough insulin around. And that's what metformin does. It basically blocks the ability of the liver to make glucose. So it's a very helpful agent in almost all of the patients with diabetes. The SGLT2 inhibitors, very low incidence of hypoglycemia with those agents. Have to be a little careful because sometimes you get diabetic ketoacidosis with those agents. And that happened to me in one of my patients. I was quite surprised, but it does happen. And then the GLP-1 or the dual are not usually associated with hypoglycemia. The DPP4, what that does is it blocks the breakdown of endogenous GPL1. You know, those have been around for a long time. Januvia, a number of other ones, sitagliptin. I don't like them. They're not very effective, and particularly when you have somebody on a GLP-1 agonist or dual. And then the thiazolidinedione, I got it right that time. That would be pioglitazone. Usually is not associated with hypoglycemia either. Almost all of my patients are overweight or have obesity. And so these days, I try my very best to get them on a GLP-1 or a dual agonist. And this is where pre-authorization, the insurance company, writing letters, and so on, that's where the nightmare comes in. But once you get them on the agents, they really are very helpful and are, I think, a real breakthrough in treatment of patients with type 2 diabetes. The SGLT2, because they cause glucose to be excreted in the urine. Glucose has 4 calories per gram. If you put out 600 grams of glucose in your urine, that's 2,400 calories. And since the SGLT2 increase the amount of glucose in the urine, they do help with weight reduction. And metformin clearly is helpful for weight reduction also. So what do you do if a patient has decreased access or need for decreased cost? Now, I have to tell you that our Black laboratory developed diabetes, and I really got upset with the cost of insulin for this dog. And somebody said, if you go to Walmart and rely on insulin, you can get a vial for $25. And that's still the case. It's NPH or it's NPH 70/30. So if you have a patient where the cost of insulin is really critical, I send them off to Walmart. That's a generic insulin that they get. There was a deal between Novo Nordisk and Walmart to get this price so low, and it's amazing, such a difference compared to other things. And they also have a meter, which comes with a kit, which is quite inexpensive. And that kit is called Rely On. So think about that, because a lot of patients really need to have this low-cost insulin. And then again, metformin, once the patients get on it, it's not very expensive. We'll talk about the glinides, GLN. Sulfonylureas, I usually use glipizide and glimepiride. I don't like those in patients that are over 70, because if they stop eating, they're going to get hypoglycemic from a sulfonylurea. And in that setting, I usually use a glinide because it's very short acting. They only take it if they have a meal. They have to take it 3 times a day, but it kind of gets around the potential having to give them a rapid acting insulin. The guidelines recommend, and this makes a lot of sense, if the hemoglobin A1C is over 7.6%, you probably want to start 2 agents at one time. If the A1C is greater than 9%, you probably want to start 3 agents at one time. And this is, again, the principle of trying to get their glucose levels down relatively quickly. So what do I do? Well, I usually start metformin in all of the type 2 patients unless there's a contraindication. Now, the contraindication is a GFR of less than 30. If the GFR is less than 60, between 30 and 60, one can just lower the dose to either 500 or 1,000, depending on how low the eGFR is. Almost everybody has some problems when you start metformin, so you need to tell them about that. And so what I do, I start at a low dose, 500 milligrams in the morning, and then do that for a week. The second week, 500 morning and evening. The third week, 1,000 in the morning, 500 at night. And the fourth week, 1,000 and 1,000. And 90% of patients do pretty well on that. About 5% have either constipation or diarrhea or nausea or just don't tolerate the drug very well. And there's not a lot you can do for that. And so those patients don't have the benefit of metformin if they can't tolerate it. But if you do it carefully, 90% can tolerate it. And then periodically you need to check for vitamin B12 deficiency, because metformin can lower that, and particularly in a patient who develops peripheral neuropathy, where B12 deficiency can cause a problem. So what do I do? If the hemoglobin A1C is under 10, I start metformin and gradually increase it. Then I add a GLP-1 agonist or a dual agonist. I really like the dual agonist because head-to-head, the GLP-GIP combination gets you better glucose control. It gets you better weight loss, about the same expense. And so I would always favor tirpesicide. If they're not under control, an SGLT2 inhibitor, then a sulfonylurea for those under 75, and repaglinide for those over 75. I like repaglinide. It's a little more effective than the other glizone. If they don't have heart disease, I'll add pioglitazone. And this 1, 2, 3, 4, 5 medication approach is really because a lot of patients just don't want to take insulin. And you can get a lot of people under pretty good control with this multiple regimen. And then if the goal isn't reached, I start with basal insulin, see how well they can be controlled. And if they aren't, then I would start basal plus prandial insulin. So how do you initiate insulin therapy? Again, these are the guidelines, but basically you're going to start at a higher dose if the patients have a higher hemoglobin A1C and a little lower dose if they're lower. So the guidelines say hemoglobin A1C less than 8%, a tenth to 2/10 of a unit per kilogram per day. 70 kilograms, that would be 14 units of insulin per day. Hemoglobin A1C greater than 8%, 70 kilogram person, they're going to be on 14 to 21 units per day. You then titrate every 2 to 3 days to reach glycemic targets. I usually do this on the phone, but the nurse practitioners that I work with give them a schedule and just tell them that they can increase it themselves depending on what their blood sugar is, and that seems to work pretty well. And then a fixed titration, another way is to adjust basal dose by 2 units until the glycemic goal is met. So this is common sense, and you can figure this out in the simplest way that meets the patient's needs. If you're talking about adjustable titration, if the blood sugar is over 180, you want to add 20% more insulin. So if they're on 20 units, you want to add 4 extra units. If their blood sugar is between 140 and 180, you go up by 10%. If the fasting blood sugar is between 110 and 139, add 1 unit of basal. Quite honestly, I don't use this. I've been doing this for such a long period of time that I have a pretty good sense of how much insulin a patient needs as we titrate it. And again, it's all depending on the severity of the hemoglobin A1C and how well the patient is compliant with things. So what about prandial insulin? So in a patient that's had type 2 diabetes for a long period of time, they're really not making much insulin at all. So when they start off with with type 2 diabetes, they have both insulin resistance and some reduction of insulin production. But over time, they really stop making insulin at all. And that's when you have to add prandial insulin at their mealtime. So you can begin by giving the prandial insulin at their largest meal, and that would be 10% of basal. So if they're on 20 units, you're going to just start with 2 units for each meal. If they're on 40 units, you're going to give them 4. And then if they're not at goal, you progress to injections before 2 or 3 meals. And again, I don't follow the rules. This all really makes sense to do this gradually. But the ultimate goal is 50% basal and 50% prandial. And it's just been shown in studies that this is really the best way to end up. Now, what about pre-mixed insulin? So if the patient can't afford insulin, I send them off to get the 70/30 from Walmart, rely on insulin, the generic insulin, and I give it generally 2/3 at breakfast and 1/3 at dinner. And then we titrate every 2 to 3 days to reach glycemic goal. Now, because this is NPH and NPH lasts up to 18 hours, if you're giving it twice a day, it's somewhat the equivalent of a very long-acting insulin. And then, because there's a short-acting component, regular insulin with it, it covers the meal. So this can work quite well. I tell patients this is a Model T insulin because we have long-acting insulins now and very rapidly acting insulins. But if they can't afford it, this is a good way to go. What about prandial insulin titration? So you can increase every 2 to 3 days. And again, if the pre-midday meal glucose is over 110, increase the morning dose by 10 to 20%. For pre-evening meal glucose greater than 140, increase the midday dose by 10 to 20%. For bedtime glucose over 140, I'm always careful about that because you can get hypoglycemia in the middle of the night. So you can increase it by 10%, but I'm very careful about that usually. Pre-mixed insulin, the 70/30, can be titrated by 2 units every 2 to 3 days, relying on the morning fasting blood glucose because of the presence of basal insulin. But you can get the Walmart NPH itself, and in some patients without the 70/30, in some patients you can get away with just the NPH, and that I usually use 3 times a day. So what about hypoglycemia? Well, the first thing is that if they're going to get hypoglycemia, I give them a glucagon kit. That's expensive, and it's easy to forget about doing that. But, you know, for somebody who gets severe hypoglycemia in the middle of the night, you save them a trip to the emergency room. The patient's wife or husband can inject this. So step one is really getting them glucagon. And then for pre-midday meal, glucose less than 70, you want to decrease this by about 10 to 20%. Pre-evening meal glucose less than 70, decrease by 10 to 20%. And for bedtime, 10 to 20%. Now, again, these are the guidelines. I don't use them. I use my common sense. And maybe it's my experience, but I end up close to this because I know pretty much how much one has to change the glucose levels. The second thing I do, I send them off to the pharmacy to get a glucose tablet. It's 5 milligrams per tablet, and I usually give them something that says that if their blood sugar is between 60 and 70, they take 2 or 10 grams. If it's between 50 and 60, they take 4. If it's under 50, they take 6 to 8. But it's just a way of not over-treating them with glucose. Because usually what happens is that they get hypoglycemia and they go out to the kitchen and drink orange juice and have 2 candy bars, and all of a sudden their blood sugar goes up to 300. With the glucose tablet, you don't have to do that. So what are the preferred GLP-1 agonists? Well, as I said, the dual tirzepatide, I like that best. It works better. Semaglutide or dulaglutide, they work. Semaglutide is oral, Rybelsus, and it has to be given fasting because the acid affects it. And now, just last month, orforglipron was approved. This is a brand new type of molecule. It's a small molecule. It's not a big peptide, and it has the GLP-1 agonist effect. And its advantage is that it can be taken anytime during the day. And the dose range is quite high, from 0.8 to about 15 milligrams a day. So with any of these, you have to dose escalate. Start with a low dose to reduce the problems with nausea, vomiting, diarrhea, constipation, and just gradually increase. So we're always asked, and until I started to look at this talk, I didn't have a good answer. But there now are 3 different regimens for maintenance when a patient has lost all their weight, and you don't want them to stay on the 15 milligrams of tirzepatide or highest dose of semaglutide and so on. So the Surmount trial on tirzepatide, they just reduced from the maximum dose, 15 milligrams, to 5 milligrams once a week, and that seemed to work pretty well. The Attain trial, the recent one, switched from maximal dose of the GLP-1 to the orforglipron tablet orally. I like that because it goes from an injectable to an easy to administer oral agent. And then what I'll do sometimes is reduce the frequency and space out the GLP-1 to every 10 to 14 days. And quite honestly, I do that sometimes in patients that have side effects of the GLP-1, nausea, vomiting, and so on. And I say, well, let's just cut it back to every 10 to 14 days, and then we can gradually increase it after that. So what are the preferred insulins? Well, if you want to have a very good basal insulin, it's best to use one that lasts 40 hours. And so there is an insulin glargine called 2JO that lasts 40 hours. There's an insulin, the Glutec Tresiba, that lasts 40 hours. And that's what I prefer. But I have a lot of trouble getting it pre-approved by the insurance and so on. Keep an eye out because insulin is Kodak acts weekly, and this has been approved in Europe. And it turns out that even though it's only one injection a week of insulin, you get less hypoglycemia and better control. So I think the insulin Kodak is going to probably take over the market for those two reasons. Now, I don't recommend regular insulin. I recommend a short-acting insulin, and that's insulin aspart, if you like, Novolog. And then you probably won't do this, but in a patient that has really severe insulin resistance, and I have patients that get up to 600 or 700 units of insulin a day, those individuals need to use U500 insulin. And it's almost paradoxical that this is regular insulin, but it actually has a rapid onset and a prolonged onset action. So with one type of insulin, it really mimics basal bolus insulin. So I use a lot of this just because the patients that are referred to me are very obese and quite insulin resistant. And then we talked about the inexpensive insulins at Walmart. So what about the cost of all this? Well, it's a nightmare to figure out the cost. And if you can write this down or you see the slides, there's a nice supplement in Diabetes Care, pages 183 to 215. That's the overall. But look at tables 9.3 and 9.4. And you can't read this slide, but it'll give you an idea of what these things cost. And it's helpful rather than going to GoodRx. You can get a pretty good idea of what the oral agents cost, and in 4 you can see what the insulins cost. So I would just say this is a good resource. It's helpful to know this, and you can always call the pharmacy or look at GoodRx, but it's a way of looking at this. So I'm going to just tell you one thing about my experience managing patients with type 2 diabetes with telemedicine. And that is most of the patients started with a hemoglobin A1C of 10.3 plus or minus 1.94%. They went down to 7.78. That was in 139 patients at 6 months. So I found it very difficult to get patients down as low as I wanted it. But just to tell you that it takes polypharmacy to get patients under control. You probably can't read this very well, but I had 65 patients who were on basal bolus insulin. So a long-acting insulin plus a short-acting insulin, and then plus or minus a sliding scale before each meal. 45 patients on the GLP-1 agonist. I'm sure it's much more in the patients that I've seen more recently. Basal insulin without bolus, 35 patients. And these are the individuals that make enough insulin at mealtime to control their postprandial insulin, but need a basal. 30 patients on sulfonylurea. You can see a few patients on the DTP4 inhibitor, Januvia mainly. NPH 70/30, U500 less, SGLT2 inhibitors. I'm using more of those now. And the thiazine, zolidone diones like pioglitazone. But this is kind of the bottom line, that 50 patients needed 2 different agents. 40 patients need 3 different agents. 35 patients needed only 1. And a few patients needed 4 or even 5 agents. So this is what I was able to achieve, only 14% at less than 6.5%, 18% between 6.6 and 7. and 27% between 7.1 and 7.5. I'm going to skip the rest of this, which is the legacy effect, showing that if you get them under control over a long period of time, it's helpful. And let me leave a little bit of time here for questions.
Dr. Santain, thank you so much. Do we have questions, Vinay, in the chat?
I'm checking right now. I think somebody is,
Could somebody read the chat if they're on there?
One.
If there's somebody on chat, maybe you could read it to me.
Okay, one question in the chat is, with mental health screenings now significantly prioritized and about 1 in 3 adults experiencing diabetes distress, what systematic changes can be made in clinical workflow to better support the psychosocial need of patients?
Yeah, I'll tell you what my easy answer is, and that's a provider that has a lot of empathy as to what's going on. But I think, at least in my own experience, you need to assess that there's a problem. And where I work, we have a mental health provider that I can refer patients to. And quite honestly, my nurse educator, who sees the patients a little more frequently than I do, will often alert me also to some of these issues. So that's what I tend to do. But I think an empathetic physician or nurse practitioner or nurse educator who listens to the patient and can see that there is a mental health problem. Sometimes this is just counseling. And what I find is patients are frightened that they have diabetes and are very distressed. That I can usually handle myself. If it's depression or major psychosocial things and so on, I refer to the mental health professional. And all of this, very important. And patients aren't going to be motivated if they're depressed or severely distressed. So this empathy and spending time listening is really quite important. I have to say, I'm very frustrated when I see patients at the University of Virginia because I've only got 20 minutes for a follow-up and 40 minutes for a new patient. And the reason I like telemedicine is I can spend as much time as I want really getting to know the patient. And this is quite helpful. So I think, to answer your question, empathy, identify the problem, a mental health professional, if you deem this to be significant enough for that referral. Does that answer your question? I guess you can't on the chat. That's okay.
Are there other questions, Vinay, in the chat?
Yes, Patricia Dupree, if you can unmute your phone and ask your question, please.
Dr. Dupree is one of our local physicians in Danville. Dr. Dupree, can you ask your question verbally? He doesn't have a mic. Okay, was there a text message from her, Vinay?
Yeah, he can do it on the chat if he wants.
Okay, so he wants to know, can you comment on the mechanism on how sumanids, and I may be pronouncing that wrong, such as HCTZ and statin increase insulin resistance, potentially aggravating type 2 diabetes?
Yeah, so hydrochlorothiazide lowers the total body potassium. And when the total body potassium is lower, it prevents or reduces the amount of insulin that's produced. So he will know that in patients that don't have diabetes, sometimes on hydrochlorothiazide, and particularly chlorthalidone, where you get more hypokalemia, you can actually bring on diabetes in those patients. But it's really because of the reduction in insulin secretion. I don't have a good handle on the statins. I think that was his second question. I haven't seen much of a problem with that. And I'll try to look that up, but I don't have an answer for the. I think that he was asking about the statins, and I don't have an answer for that.
Other questions of Renee in the chat?
Are there any tips for managing patients working night shifts that I can't get controlled?
Yeah, so if the patient has a need for insulin, the long-acting insulin, the 40-hour acting insulin, gives you a very stable level of insulin over the 24 hours. It lasts 40 hours, so if you give it every day, the levels are quite stable. And then what you can do is just give the prandial insulin at the mealtime, which is going to be different because the patients are working at nighttime. And that seems to work pretty well if the patient is on insulin. The other part of that is that if the patient is really stressed at work and needs a lot more insulin, basal insulin at nighttime, during the daytime, the Omnipod, which is the patch, which is a needle, you can alter the basal rate any way you want to with that. And most nurse practitioners, primary care physicians, and so on are not very cognizant of the Omnipod. And so those patients, it's helpful to refer to an endocrinologist and get them started on it. Once they're on the Omnipod, it's very easy. The patients learn how to alter the dosage at the time that they want to. But I think just the long-acting basal insulin plus the short-acting rapid, and then tailoring it to the nighttime. And a lot of those patients then have swing shifts. So they work at night, and then the next time they work the day shift, and the next time they work the evening shift.
Or
With the basal bolus, they can basically switch the timing based on the time that they're eating. I hope that was helpful for you.
right.
Our next question, Janet Durham, if you can speak up with your question, is right lengthy.
My question is regarding the newer ACE guidelines with evaluations for hypercortisolism in patients with type 2 diabetes. With a growing discussion around endogenous hypercortisolism as an under-recognized contributor to difficult to control type 2 diabetes and metabolic disease, including some of the research from Ralph DeFranzo regarding insulin resistance and hypercortisolism, are you incorporating screenings more routinely in patients with resistant hyperglycemia, obesity, hypertension, or multiple metabolic comorbidities? And I was also curious about your thoughts on treatment approaches once hypercortisolism is identified, specifically on the use of Korlym and Isturisa, and where you see this fitting into management of diabetic patients with confirmed hypercortisolism and Cushing syndrome.
Yeah, I have to say I'm an old dog and a little slow to incorporate new tricks. So I really just look very carefully in patients to see if I think there's any evidence of hypercortisolism. The usual things that you'd look at for Cushing syndrome. A couple of weeks ago, I had a patient that had mood and facies, and I was quite concerned. We did an overnight DEX suppression test, and she didn't suppress normally. So I don't do that routinely, and I would have to be convinced, I think, that it's cost effective to do that. But if you get an AM cortisol at 8 in the morning, if it's over 12, the patient has normal, can make cortisol normally. If they're over 25, one is concerned about that. So maybe I'm not doing it properly. I don't tend to do that. And if they do have an elevated cortisol, we do have a number of agents now that block 11-beta hydroxysteroid dehydrogenase, which will lower the cortisol levels, and one can do that. I don't personally think that elevated cortisol in these patients is playing a major role. And, you know, you've tweaked me a little bit, so I'll think a little more about it. But no, I don't do it myself.
Other questions, Vinay, in the chat?
There are no other questions in the chat.
I'm going to take advantage of asking one about the, you said the new product coming out as once a week insulin. How does one dose that? Does one just titrate it at weekly views versus what would be daily or hourly views?
Yeah, so I obviously haven't used it, so I can't tell you about personal experience, but the and I thought for a long time that this would be very useful, actually. So I would start at 1/7 the dose that you would ordinary. I'm sorry, 7 times the dose that you would ordinarily start a patient on. But I'm going to have to look at the I'm going to have to look at the way they did it in Europe. It's quite interesting. They started low and gradually
Sure.
dose escalated, and you know, common sense to do that. But it was really quite surprising that patients had a very low incidence of hypoglycemia. And I think that's probably because, if you like the term zero order kinetics or stable blood levels, I think that was the reason. And I have to say, almost 40 years ago, I thought to myself, because I was using a long-acting GnRH, a long-acting leuprolide, GnRH agonist, that they should do this for insulin. You know, it would be very, very helpful. So we'll have it soon, and it has been approved in Europe at this point.
Thanks.
That's about the best I can do. But
That's pretty good. That's pretty good.
I'd have to go back and look.
Any last questions for either of our two speakers tonight? We have them both on the call. Okay, well, this has just been a terrific session. We set some records tonight. Normally in our registration, we have about 75% of folks who registered to actually be on the program. Tonight, we actually exceeded, I think, registration. So we had we're just so pleased when that happens. And I'm grateful for all the comments that came after the talk. Both these presentations were just really well done. And to Dr. O'Neill and Dr. Centine, it's just been a privilege to have both of you on the program this evening. I think you've stimulated everyone. For everyone on the call, don't forget to look at, if you've not looked at the guidelines, it's Diabetes Care, that's the journal name. And then you just have to type in Supplement 1 2026. It'll open up and you can download it free. You don't have to have a subscription, and you can bring the PDF back. It is huge. So you have to, bring a hand truck to get the thing off the printer and so forth. But it does delineate everything, and it is consensus-based, evidence-based medicine. So that being said, I hope we can see everybody back on June 11th for the second in our series of ER or acute trauma management. It's some very, very interesting stuff. And other than that, I thank our speakers yet again. Vinay, thank you for managing the program and everyone for being on the call. We hope we'll see everyone back on the program in June. Other than that, have a great night and take care. Bye-bye.
Bye.
Thanks, Dr. Centine and Dr. O'Neill.